So hello, everyone, and welcome to Partners in Pain. My name is Erin Sobkow, and I will be your facilitator for today's session. Thank you for joining us. Before we begin, in the spirit of truth and reconciliation, I want to acknowledge that I live on Treaty 4 territory in Saskatchewan. Now, some background with Partners in Pain. It grew out of the Improving Pain in Saskatchewan Collaborative Research Project. The research project aims to give pain a voice by bringing people together to share information and plan action to improve how pain is managed in our province. The research project led to our first pilot series of Partners in Pain webinars in March of 2021. The feedback from the pilot was very positive and led the research team to seek additional funding to help support the continuation of the webinars. Partners in Pain received a Community Initiatives Fund community grant in mid-2021 for an additional series of webinars, which is what brings us here today. All of this work is supported by Sask Pain organization, which is on a mission to help improve the lives of those living with pain in Saskatchewan. So just a few webinar reminders or etiquette reminders before we continue on. Please keep yourself muted while our presenter is speaking to minimize background noise. We are certainly happy to see your faces and feel free to keep your video on. But if you notice that you are having connection troubles, then maybe you want to try it with your video off. There will be an opportunity to ask questions, so please submit your questions in the chat and I will answer them as we go. I'll share them with our presenter. So now it is my pleasure to introduce you to our first speaker for today, Jessica Jack. Jessica is a master's student in medical anthropology at the University of Saskatchewan, a research assistant with the Improving Pain in Saskatchewan Research Project, and also has her own lived experience with pain. When she's not working, she loves yoga and hanging out with her partner and her dog. So Jessica.
Thank you so much, Erin. Let me just share my presentation here so you can all see it. Can everyone see that okay? Thumbs up? Awesome. Great. Thanks, everyone. So, well, Erin gave me an excellent introduction, so I'm not going to belabor the point too much, but I will explain a little bit about what a medical anthropologist is. It just means that I research the way that culture influences health, wellness, and medicine. So that's going to be the focus of our topic or our talk today. So to start with, let's begin by understanding what I mean when I say culture. So culture is basically how a group of people create connections and similarities with each other. Culture comes from and creates beliefs like what is right and what is wrong. Customs like saying it's nice to meet you when you greet a stranger. It makes creative expressions like what we think of as being art and music, and it influences our institutions like our medical system and how it contributes to ideas about being Canadian. So culture also influences so many aspects of our lives. Generally speaking, we're not really aware of this influence because it happens thousands of times a day in ways that range from direct, such as calling a woolen hat a toque, to subconscious, like craving pierogies for supper. So because of this mix of the explicit and the implicit, culture shapes who we are, how we do things, how we think and talk, our morals, our goals, and most importantly for our time together today, the stories that we tell. So we're going to be talking about narratives, and narratives are the stories present in our everyday lives. These narratives are important because they act as subconscious scripts for how we should think, act, and talk in response to specific situations. So you're probably not aware of it, but the stories that we build into things teach you what's right in a situation, what's wrong, and how to act. It's basically a guide on how to act in any given situation. So my favorite example of medical narratives centers around the common cold. So there's a narrative that if you get cold, like if you go out into the cold temperature, especially if you go out in the cold with wet hair, that you will actually catch a cold. So this is the narrative. You go out in the cold, you catch a cold. But it's actually a handy story to help simply explain the increase of colds during the winter, which actually happens because you're spending more time indoors around other people, because the cold virus survives more easily at lower temperatures, and because some people experience immune suppression from being exposed to cold temperatures and dry air. Another narrative about the common cold is that chicken soup is an excellent remedy for a common cold. Well, I mean, yes, it is, but it doesn't have to be chicken soup. Chicken soup just happens to combine needed protein in easy to eat small pieces, soft noodles that won't irritate your throat. It's warm, which helps to soothe congested sinuses and ease throat irritation. And it's mostly liquid, which your immune system needs to deal with the virus. So without me explaining why we get colds or why chicken soup is good for a cold, you already knew these narratives. And these narratives are cultural because people in places like India and Japan have very different understandings and approaches to the different viruses that we call the common cold. So narratives like these shape our knowledge and our behavior. Now let's shift to talk about narratives surrounding pain. So I'll start with an example. If you were with a kid who scrapes their knee, how do you think you'd respond? Most of us would say something like, oh, it's okay, it's just a scrape, you'll be fine, because that's the narrative about kids and small injuries like boo-boos, Again, you'll probably never set out to learn that that's how you should respond to a kid with minor pain, but cultural narratives have taught you that this is the correct action. And the next time that that kid scrapes their knee, they might respond differently because you've begun teaching them this narrative about pain. So this is because cultural narratives about pain teach us how to think about and respond to pain. And when I say us, I mean literally everyone. No one in any culture is exempt from these narratives, and it influences us all at levels at which we're just not aware. These narratives are present between you and the medical professionals from whom you seek care. You make an appointment, you show up on time, you tell the doctor what's wrong, they ask a few questions, and then send you on your way with either suggestions, a prescription, or a referral. For the most part, neither you nor the medical professionals that you see have to think about doing things this way because you both know the story. This is just how things go. The same applies to narratives about pain involving your friends and your family. Once they find out you're living with pain, they're expected to react in specific ways, either offering sympathy and support, maybe picking up tasks or chores that you might now need help with, things like that. But pain narratives also mean that generally they're expected to feel a little bit sorry for us, to compare their situation to yours, to maybe even begin to see people like us as a bit of a different person because of the pain that we're experiencing. And this can change your relationship with these people because pain narratives unfortunately create distance between us, the people living with pain, and others who don't understand what that experience is like. This is because narratives often provide us with a common frame of reference, a way to see and understand new situations that could otherwise be troubling or difficult. And in much of North America, these narratives involve creating categories of us versus them, healthy versus unhealthy, able versus disabled. Again, most of this happens so subconsciously that we're not aware that we're doing it, but we do become aware of the way these narratives impact us. Part of that impact could be the way that narratives influence how you think and feel about yourself. So stop and think for a moment. Outside of pain advocacy circles, do you know anyone in serious positions of power and authority that publicly live with chronic pain? Premiers, prime ministers, CEOs, the majority of celebrities, a few exceptions in there, but the majority of celebrities, generally speaking, they're presented as being healthy people with no pain. And that's because one of the narratives about pain is that if you experience pain, it means you're not strong enough. Pain is equated with weakness and is therefore not seen as a desirable trait. We get these messages from seeing and hearing these people in positions of power and begin to think that way about everything, including ourselves, without even realizing it. I can't speak for you, but I know that it took me years of hard work to unlearn that particular narrative and the mental health problems that it caused me, because my self-esteem and my self-worth were tied up in my apparent weakness for just living with pain. It can be subtle and it can be very, very sneaky, but the narratives that we hear about pain change our relationships with ourselves. So I wanted to share with you some of the common narratives about pain that circulate in Canadian and specifically in Saskatchewan culture. So some of these narratives came to light in the Improving Pain in Saskatchewan project, and some I know from paying attention to my own experiences. There are a lot more pain narratives than this, don't get me wrong, but these ones were just particularly accessible examples. So the first is the drug-seeking narrative. As many of us know, pain is often difficult to see for doctors, meaning to diagnostically have proof of it, because in many cases, there's no broken bones or cancer diagnosis to prove that there is a source of pain. Couple this with the fact that the first treatment option for pain is often controlled substances like opiates, and we have the fodder for an unhelpful narrative about pain that most people know as drug seeking. According to this narrative, people addicted to drugs often go to emergency departments and doctors' offices and make up or exaggerate their pain in order to get drugs. The truth about this narrative is, of course, far more complicated than that. Drug seekers often have very legitimate reasons for their requests, but narratives paint them in a specific way. Oftentimes, drug seekers are people looking for help, but don't know how to get it the right way as set out by pain narratives. The drug seeker narrative hides the complex reality of people needing pharmaceutical support for their pain. The second narrative is another familiar one, the "it's all in your head" narrative. As we all know, there are a few things more infuriating for someone living with pain than to hear "it's all in your head." But the narrative of pain being made up or psychological and therefore being irrelevant or not of serious concern is incredibly prevalent. If you don't have an identifiable physical source for your pain, it isn't seen as real pain. So from this narrative, if doctors can't diagnose the source of your pain, they just send you to therapists or psychiatrists with the note that sometimes the patient just needs someone to talk to. Basically, pain is dismissed as anxiety, depression, mental illness, or attention seeking. And as we know, the reality is that pain is an incredibly complex thing. For a pain patient to be told that it's in their head and they just need to talk it out is incredibly dismissive of that person's lived experience. And unfortunately, it has stigmatized mental health care needs for people living with pain. By trivializing pain in the context of mental health, these narratives reduce people's ability to access needed mental health care and also wrongly funnel patients towards unneeded mental health care. The third narrative is often unspoken, but it comes across loud and clear in actions and appointments. The "it's not my problem" narrative. So there's a stereotype about pain patients in the medical world. We are lazy, we're needy, and we need a lot of hand-holding. Because of how doctors are reimbursed for their time here in Saskatchewan, generally being paid by the patient, not by the hour, doctors want to see as many patients as possible in a day. So if a pain patient is asking questions the doctor doesn't know the answer to, the force of this narrative comes into play to say, well, that's not my problem. It comes across as doctors not making, it comes across in doctors not making room beyond the bare minimum needed to, not making room for their patients to ask questions, not communicating with the patient beyond the bare minimum needed to make appointments, and not suggesting treatments or care options beyond their usual playbook. As we know, when doctors abdicate responsibility for helping us with our pain problems, there's frequently nowhere else to turn. That's because these narratives teach us that doctors should have all the answers. They should know what to do, and they should want to help us. Medical institutions have listened to this narrative and put most of their eggs in the doctor basket, leaving little external support for people living with pain who are left to navigate complex and confusing systems on their own. And they're expected to research care and treatment options without the help of years of schooling and training to know what to look for and where to find it. The last two narratives are two sides of the same coin. So when we're living with pain, we're expected to either be the hero or the loser. The hero narrative is that you develop pain and you face that pain head on, showing nothing but bravery, stoically bearing the weight of your burdens and putting a happy face on everything. Your pain is simply a way to showcase how much of a hero you really are. And while it sucks to deal with your pain, you just deal with it. On the other hand, the loser narrative is the opposite. Something happens to you and you fall into the pain hole and you're unable to escape. You become addicted to drugs, you quit your job, you abandon your family, and you become a drain on society. This is because you were not strong enough to overcome your pain and you deserve this downfall. And many doctors ascribe to these narratives, whether consciously or subconsciously, and reduce the complexity of pain to how you react. Do you react the right way or not? If you don't follow these narratives, doctors are often heavily focused on what's wrong with you instead of how do we fix your pain. I hope I don't have to deconstruct this one too much, because if we've experienced pain, we know it's not that simple. It's not you're just a hero or you're just a loser. There might be days where we feel like we fit the hero narrative by, putting on the everything's okay face and just making it through the day. And there might be days where we feel like the loser, where the pain is overwhelming and it feels like nothing we can do makes a difference. But ultimately, experiences of pain are widely varied and have nothing to do with your worth as a person. But you may feel like it does because of these insidious narratives about pain. So obviously, pain narratives can make it difficult to get the care that you need when you need it and make you feel like you've been respected as a human being while you get that care. Unfortunately, cultural narratives like this can be difficult to stop or change because they don't come from any one specific place or are spread by one specific person. But there are some things you can do to mitigate the impact of these narratives. The first is honestly accepting that you can't stop pain narratives from happening. They come from social forces much larger than any one particular person and are perpetuated by huge groups of people. Trying to control these narratives or stop them at all from applying to you can take huge amounts of time and energy. Believe me, I've tried, and all I got for my efforts was a feeling of failure because I couldn't achieve that control. Accepting that these narratives exist and realizing that you don't have to conform to them can be a very freeing and empowering experience. The second is honestly just being aware of these narratives. Hopefully after our session today, you'll be able to begin to notice them when you're out in the world. Being aware of narratives means you can recognize them and, most importantly, help other people around you begin to recognize them too. In appointments, in conversations, in your own thoughts and your feelings, you can start to ask questions like, why do you believe that? Or, oh, okay, what makes you say that? These questions aren't meant to be confrontations, but genuine curiosity about why people say and believe these things. And as you have these conversations, people might begin to see the narratives for themselves and realize that they don't have to follow them either. As a personal anecdote, this happened to me when my best friend casually told me in conversation that she hadn't invited me to a party she threw because she knew that my pain probably meant I wanted to be alone. I asked her why she said that, and we ended up having a 2-hour conversation about the isolation of living with pain, my need for social engagement and support, and how she might have been contributing to my isolation by presuming that my pain made it impossible for me to have a normal social life. She's actually now one of my biggest supporters, but I don't know if she would have been without this new awareness of pain narratives. And lastly, the third point is kind of extension of the second one. In some ways, advocacy is really the practice of critiquing these narratives and asking for change to reflect the reality that is hidden by these narratives. So by advocating for change from insurance companies, medical systems, and governmental support, and the general public, just to name a few, we can begin to change these narratives and shift their impact on everyone, not just those of us who live with pain. So in summary, culture is all around us and is constantly influencing us. As part of our culture, we tell stories or narratives that shape how we think, act, and feel. Cultural narratives about pain are widespread and contribute to a lot of the problems surrounding pain. And knowing about these narratives can help you see through them to the reality that they're trying to explain. So thank you guys very much for your time and attention, and I appreciate you listening.
Thank you, Jessica. That was very interesting. Great job. Does anyone have any questions for Jessica? Did anything spring to mind or any thoughts? I know what I was thinking when you were presenting.
Sure.
My grandma is 94 and her narrative is she doesn't want to take pain meds because she might get addicted. And we say to her, Grandma, you're 94. It's okay. You can take pain meds. But, you know, that obviously was something that she grew up with or that was in her head.
Absolutely. And that's a really, really common narrative. It's amazing how many people are under medicating their pain because, you know, opiates have become this highly demonized thing as part of our cultural narrative. And that comes from a very real place, you know, the overprescribing of medication and, you know, the rising levels of substance abuse and those kinds of things. But unfortunately, narrative gets rid of all the fine details around the edges and kind of just concentrates things into one specific, very, very generalized story. And I just contradicted myself. It's a generalized story, not a specific story, but it doesn't make room for reality, you know? And so unfortunately, some people just will continue to adhere to these narratives kind of forever, because some people, they just can't change their minds, but they are definitely changeable with conversation, you know, if the person is open to it.
Yeah. I don't think we're changing her mind.
At 94, I think I would probably be stuck in my ways too.
But we all think that she'd have way less pain if she took something.
Yep. Yeah, exactly.
Does anyone else have any questions? I found this very interesting, this whole topic, working in healthcare myself. Have you, with your research, figured out any ways that you yourself or your research is advocating for this in Saskatchewan for change?
That is a good question. I like to think that the Improving Pain in Saskatchewan project is inherently an advocacy project because we're going out there and trying to make the results of our study public and therefore, you know, show people that pain is complicated and is a really serious problem. And so that helps to deconstruct some of these essentializing narratives. But other than that, honestly, I think the biggest advocacy piece that I have ever seen is just being public about the fact that you do have pain, because not talking about it allows these narratives to continue without being challenged. So posting it to Facebook, you know, I've got chronic pain and this is a really bad pain day, is in itself a form of advocacy. So I don't know if I can be more specific than that, but advocacy itself is always refuting narratives.
Mm-hmm. Yeah, good point. So Colleen is asking, do you have any ideas on how to convince doctors that you're not just drug seeking?
It depends on the doctor, of course, but I would suggest that being very specific about the reasons why you're asking for that medication, even if it's just from your own personal experience, like, I noticed that when I do XYZ, my pain increases, but when I take this medication, it impacts my pain in XYZ kinds of ways, rather than just being more general about it and saying, I'm in pain, I need meds, because by giving them those details, it starts to break down those larger narratives, because narratives rely on things being very generalized. So details can help pick apart at the areas where it's a problem. Or on the flip side, just saying, okay, you seem resistant to this treatment method. Can you explain to me why? And then start to have that conversation. So.
Yeah, thank you. So Donna says, thank you, Jessica. She undertreats her pain as well. And Kathy says that it's so important for healthcare providers to understand their own potential biases or beliefs that may have an impact on helping people living with pain to attain their own pain management goals. There can be a time and place for opioids, but they are not the only option. And Celine says, great comment, Kathy. And I would agree. For myself too, as a massage therapist, I used to be when I first started, don't take drugs. And then having a nursing husband and really understanding now how drugs work and why when you initially have pain, you might want to take something and take it frequently at the start is important. And Donna says, details and written documentation for physicians are helpful to bring with you to appointments. Absolutely. Yeah. Any other comments? This is a really good discussion.
I just wanted to comment and say you did a fantastic presentation, Jessica. Thank you so much for that.
Thank you, Dana. I appreciate that.
Really well done. Well done.
Yeah, it was well done. Any last comments or questions before we move on? All right. People are just saying thank you. So we'll move on. And if you guys think of something else as we go, you can always put it into the chat. So now we have our speaker, and it is my pleasure to introduce you to Tracy Fichtner. Tracy will be sharing her lived experience with pain. Tracy lives in rural Saskatchewan. There's never a dull moment with her husband, who runs a self-employed home construction business and having 2 children in post-secondary education. Tracy has lived most of her life in Yorkton. She is a registered nurse in her 32nd year of work in Yorkton. Tracy also worked for over 26 years in the Yorkton Hospital, 24 of those years in ICU. As an RN, Tracy thought she knew quite a lot about how to treat pain, but found she was sadly mistaken. After 3 work-related injuries, back and shoulders, she was unable to continue working in acute care and now works in primary health care. She has tried many different treatments and still applies multiple approaches to manage her daily chronic pain. Tracy?
Thanks, Erin. So first of all, I'm sorry that the sun is shining in on my face and you can only see half of it. But on the other hand, I never see the sun when I am at work. So this is really nice to see some daylight. So I hope you can put up with the light shining. But in August of 2014, I was working a stretch of 3 12-hour shifts in ICU with heavy workload. And although I felt strains from patient care, I was able to keep on working. But the morning after those 3 shifts, I woke up feeling like a blade was stuck between my neck and my shoulder, painful golf ball-like lump under the shoulder blade. I had limited range of motion of the shoulder and numbness and tingling down into the hand. And as the morning went on, I got the worst headache ever with this burning pain in the right side of my face going into the ear and jaw. And I'd get dizzy if I turned my head to the right. And so because of the diversity of these symptoms, I had many tests and referrals to the spine pathway, a surgeon, and a neurologist over the next 4.5 months. As information changed after each appointment, I unexpectedly felt belittled or maybe even scrutinized when people or coworkers would ask about my injury, the healing, or the treatment plan. It seemed my explanations triggered more questions, confusions, and then my own self-doubt. Poor pain control led to days where I'd kind of crawl into the most comfortable position and try not to move. But then that led to isolation And that was really detrimental to my relationships, my coping, and it was a really dark place psychologically. My final diagnosis of repetitive strain injury causing myofascial pain syndrome, isn't that a mouthful, was based on ruling out other diagnoses. By this time, I had a frozen left shoulder with very painful knots that I learned later were trigger points around the shoulder blade. My left shoulder blade was poked out and it was higher than the right one, and my left collarbone was crooked and felt choky. And like I had said earlier, being an RN for 26 years at that point, I thought I knew how to manage pain, but I had no idea how to manage chronic pain. So all of that led to a long program at rehabilitation full of physical and emotional challenges. And as we progressed, I felt like an onion when we were peeling away these unpleasant layers each week. Despite having a wonderful life with stable family relationships, a strong social network, financial security and medical benefits from my job, early in my process, my thought patterns got pretty dark pretty fast. Although pushing myself beyond my limits some days just to get through the day, I still felt like people were not satisfied with my responses or my efforts. Encouraging comments were being lost, and I was focusing on all of the negatives. I struggled to force a positive perspective each day. And what I learned was a vicious cycle of a pain-centered life and ineffective pain management had stripped away my control and my quality of life. And I just felt like I needed to escape. Thankfully, I met professionals who heard my concerns of ineffective pain management with medication and my requests for alternative pain management. Trigger point injection therapy and mindfulness training were pivotal. This gave me hope and allowed me to achieve a positive focus to persevere through this difficult physio. We quickly incorporated what was called brain training, and this involved understanding how I interpreted the pain signals and then telling my brain that the pain I felt. So for example, it didn't have to remain hot. And when I thought about it, I visualized the color red. Instead, I started convincing my brain that the pain felt cool, and I focused on visualizing the color blue. And that allowed me to better tolerate the manual manipulation treatments of this frozen left shoulder, and even resulted in goosebumps forming on my skin one time. It was pretty cool. Techniques that I still use today are imagining a slinky inside my rib cage expanding out or up, helping my coordination to be able to isolate tight and difficult muscle movements. Breathing into an area like the back of my shoulder blade helps to focus my brain to target muscle control of a specific area during those stretches. Mindfulness, as I know this now to be, were pivotal in my recovery. During this time, one of my colleagues was a member of the Saskatchewan Registered Nurses Association professional practice group, and they were planning an upcoming provincial pain conference. She was very interested in the techniques we were using in rehab, such as guided meditation, biofeedback, trigger point injections, and dry needling. I shared how my previous work-related injuries, pre-existing endometriosis, cervicogenic headaches, and bruxism or jaw clenching, along with being a worrywart, a people pleaser, and a detail-oriented person, impacts my nervous system and then in turn my chronic pain. So that led to an invitation to present my pain experience at the provincial conference in 2016. And afterwards, I remember saying to her that I thought it was very cathartic for me to speak, which I immediately thought was weird because I didn't really understand that word until that moment. But preparing for that conference ended up being a fantastic distraction for me while I was in rehab. And afterwards, while I was struggling to adjust with my modified work accommodation or duty to accommodate. Despite a fantastic physiotherapist who advocated for me to get 3 extensions in my return to work, ultimately I had to cope with not successfully returning to work in ICU, being unfit to work in any acute care position, and I was still in pain, needing more rehab. So I had to figure out how to keep the ball rolling and form my own team. So I contacted a registered massage therapist that I was familiar with, and soon she suggested adding in chiro and dry needling again. I was eventually brave enough to seek out chiro treatments with active release therapy, but I didn't rush back into dry needling. Although I knew it worked really well for me, to be honest, I was scared to start with a new provider. In 2019, I found a physiotherapist that I trusted, and after one assessment, she suggested dry needling again. And that treatment did work very effective for me. The muscle twitch, or in my case, the contraction that was produced, was painful, but it awakened dull muscles that weren't moving properly and allowed overstretched muscles to relax. Eventually, it became so effective that sometimes it would relieve my headaches with face pain. This was not a quick and easy process, though. I used dry needling for over a year when another medical condition prevented me from continuing. And I also continued to have great support from my GP's office. And in the last year, Botox injections have been successful treatment for bruxism, or jaw clenching, that I've had since I was a kid and failed to be, I guess, treated appropriately and effectively despite many forms of therapy. With not being able to continue dry needling and the recurrence of almost daily headaches with face pain, I needed to find a new solution to maintain the pain relief that I had once had and the muscle progress that I'd made. I was also unhappy with the medication effects and side effects and with the overall poor quality of my life. Pain seemed to control my life. Headaches interfered with my cognition and my memory. Lack of sleep and fatigue prevented me from doing much of anything. And I thought, this can't be as good as it gets. So I looked around and I decided to self-refer to the Medication Assessment Center last spring. And this multidisciplinary team has dramatically helped reduce my level of pain and improve my quality of life. My team has grown to include a pharmacist, a physiotherapist, a registered dietitian, and a social worker. I love it because nothing is ever told to me. I'm listened to, validated, encouraged, and suggestions are offered. And each month we reassess my self-management strategies, continue to make medication changes, and we modify my activities. I have learned more about nutrition and the brain-pain connections, how triggers from food, beverages, and stress all can flare my pain, and how to manage it. And all of this continues to reinforce how important it is for me to self-manage and monitor the vicious pain cycle. And learning about that pain cycle was a real game changer for me. I honestly felt like a hamster going around and round on this little wheel, recycling the same problems caused by chronic pain. This helped me to better learn ways to manage the problems and then aim to manage chronic pain better. So when I start having more pain, I look to see what else is going on in my life. And I think, well, what about sleep? How is my sleep? Is it effective, or am I not sleeping well? Or what about activity? Have I overdone it, or have I slacked in some areas? What about food triggers? Have I been eating something, or, we were talking about chocolate. Did I dive into that and I've eaten some triggers for pain? So sometimes I need to work on another area as well as treating my pain to get things under control. I also have a sticky note that I brought with me. I have it in the fridge and in my bathroom mirror, and it has all of my tools labeled on it. I don't know if you can see it, but it says breathing, mindfulness, nutrition, sleep, hydration, activity, up shifts, down shifts, manage stress, medications, prayer, pacing and planning, all these great tools that I can use to manage my pain. But sometimes I'm focused on a lot of other things and I'm not paying attention, and all of a sudden that pain cycle has reconnected and I'm in a bit of a pickle. So this is a really good reminder for me to use those tools daily, not just hit and miss. Along the way, though, I experienced some miscommunications with healthcare providers regarding pain and pain management. Part of this was due to my impaired memory. Part was due to my own personality, work ethic, and beliefs about pain, what Jessica just finished talking about. And part was that acute care, community care, and rehab can have very different approaches to pain and pain management. Messages like don't work into your pain and use pain as your guide were confusing to me during rehab. I always was in pain, and most movements induced new pain. Avoidance of pain also wasn't going to allow me to get through the frozen shoulder and achieve my goals for recovery. Manage your workload was a phrase that I didn't know how to implement. I didn't know what my end point was. So I found myself not managing my workload, working well into fatigue tissues that took too long to recover. I'm fortunate to have visible pain signs. I get asymmetrical redness or warmth of the neck and the ear. I get vocal changes, musculoskeletal asymmetry. My arm will get discolored. I get word inversions, and I have visible eye fatigue. But I'm also blessed to be around people who identify my pain signs that I can't detect because of sensory overload or fatigue, or because, as I refer to it, I can't see the forest for the trees. I honestly couldn't answer questions from people like, why are you at work today? Or are you able to look at a patient care situation and say, I'm out? No, I couldn't. My perspective gets distorted due to pain signals and fatigue. And hurt versus harm was also not well received the first time. A lot of movements felt like they were harmful to my tissues, like the frozen shoulder manipulation or the dry needling treatments. I learned these were hurtful, though not harmful. I now call it my good pain. It's pain with a purpose to help me achieve a goal. And I focus on that good pain when we're going through treatments. Acceptance was a hard one for me. I cycled around with anger, frustration, irritation, basically varying degrees of being generally annoyed with my pain and how it restricted my life. I also struggled with doing the daily self-care routines that my pain required. I was trying to get back to my normal pre-chronic pain self that didn't require much maintenance, and that just wasn't happening. I needed to learn to accept that I lived with chronic pain and move forward. So today I still struggle with tightness and tension that restricts smooth, consistent muscle movement, along with proper posture and positioning. I can see in the camera that I need to do that. Headaches still cause trouble cerebrating. I mix up numbers, letters, words, and it still causes some poor memory. Sleep and fatigue are still challenging. However, all of this is improving. I'm more functional than I was a year ago, and I'm becoming more confident. Pacing and planning is still tricky. My brain often has a different agenda than my body does when I want to accomplish something. But despite all of this, I'm always learning. For a long time, I fought with stretches and exercises. I don't fight with them anymore. If my body won't cooperate, I do something else. I used to take medication when I couldn't stand it, and now I treat pain earlier and I use less medication. Change is still scary, but one thing I've learned to say to myself when I'm contemplating a new treatment is, okay, what if it doesn't help? But what if it does? That's the real part that makes you think maybe you should go for it. And occasions like this to share my pain journey, they are intimidating, and it does take a lot of time to put my thoughts into words. However, it's so worth it. It provides me an opportunity to review where I am, reflect where I was, and realize how far I have come. And for those of you out there who are living with pain, maybe you're thinking about doing something like this, consider it. It's so good for you to do something like this and to be able to share your story. Thank you for taking the time to listen to mine.
That was excellent, Tracy. Does anyone have any questions for Tracy? Any questions at all?
I'll ask one if that's okay.
Sure.
So Tracy, you mentioned that you had to kind of overcome the beliefs that you had about pain, and you referenced my talk. So I was just wondering if you could maybe expand on that a little bit. What did you have to work with there?
Absolutely. So I don't know whether it's just my personality or, and same with work ethic. My mom was a very hard worker and did everything really well and to the best of her abilities all the time. And I learned that trait. And so when my body wasn't cooperating and I was having a lot of pain, I wanted to work really hard and do absolutely everything that I could to try to have the best recovery that I could and get back to where I was. And that's where acceptance was hard, because there was a point where I had to accept I wasn't going to be able to, hard work wasn't going to get me back there. And it didn't matter how hard I worked with or without medication, distorted my cognition and slurred my speech. And so if I took it, then that meant I was going to isolate and then maybe not be as social as well. So all of those beliefs were my own intrinsic beliefs. Part of it might have stemmed from how I was raised and how we grew up. Part of it was being a nurse. I wanted everything to be just right and do everything that I could, and there should be a start, a plan, and an outcome, and that wasn't happening. So, but that's all me. I don't know that other people put that on me. That was something I think I had within me, and maybe it is a stigma. I don't know. The other thing was go hard, or that one. I had to throw that one out because that wasn't a good saying.
Thank you for sharing. I just wanted to note that everything you mentioned, all I saw was heads nodding. Like, it was so relatable the whole time you were talking. So thank you.
Thank you for the feedback. That's good.
Yeah, that was really good. Good explanation of that for sure. And different personal biases, I guess you have. Dawn is sharing that she was so frustrated when her doctor wouldn't listen to her about her pain. She was told to stretch it out. She says that it took her 8 months to finally get someone to hear me, and the end result was more medical issues resulting in chronic pain and mobility issues.
Yeah, it's really frustrating when you aren't heard. And like Jessica said, trying to find tangible or objective ways to describe what you're going through so that it won't be dismissed and that you will be heard. That's really hard. I'm finding, as I'm coaching my own patients now who are just beginning their journey with chronic pain, that's a big one that we work on, is preparing for your doctor's appointment and having ways to objectify your pain through terms, through a number scale, through limitations, what makes it worse, what makes it better, and what it prevents you from doing.
Mm-hmm. Does anyone else have any questions before we move on?
Tracy, I want to say you did fantastic. I told you.
Thank you, Dana. It's because you're cheering me on.
You always.
All right. Thanks again, Tracy, for sharing your pain experience.
You're welcome.
Okay, so now we'll move on to the activity which I'm doing. So Celine, if you could share the PowerPoint. So we thought it would be great to talk a little bit about leisure education. And leisure education is taught through kinesiology. So when I did my kinesiology degree, we did leisure education. That was 20 years ago. And now, more recently, at the U of R, people are taking this through therapeutic recreation. So it's a therapeutic recreation degree, and they focus a lot on leisure education, and especially on recreational focus with therapeutics. So there is a field of study with this, and it's very interesting. Okay. Celine, are you going to be my move forward?
I sure am. Sorry, Erin. I'm just trying to move it on here.
That's okay.
There we go.
All right. So leisure education helps participants gain a better understanding of how, when, why, and with whom you can pursue leisure experiences and interests. Leisure itself refers to activities that people choose to engage in your free time. So what do you like to do in your free time? The positive use of leisure is linked to identity development. And so this, I was thinking, in terms of biases with chronic pain, this ties back to the biases of your identity, right? So can leisure help to break those barriers or those biases if you would be the person that would tend not to do anything because of chronic pain? Can you start to do something or pursue some leisure interests? What participating in leisure also helps you to do is to develop coping skills, to reduce your stress, to help with activity innovation. It increases your physical activity, your socialization, so you're talking with your friends, academic and community engagement, and as well as your health and well-being. So lots of positive experiences. Sometimes you hear about leisure sampling, and leisure sampling means to try a wide variety of activities in the hopes that you will find something that you love to do. And I was in another webinar where someone had said they enjoyed something and it takes their mind off of their chronic pain. So this is perhaps one way to look at this. And research also shows that activities that you try in your childhood, you are more likely to do in your adulthood because they're familiar to you, you have muscle memory, and you're not scared to do them because you've done them before. So we like to think for, especially with kids, you want them to access a wide variety of activities. It doesn't mean that you can't try these things as an adult, but you're more likely to do something that you tried as a kid. So now we're going to do our activity. And this activity is you are going to Leisure Island for 1 week, and you can only take 5 of these items with you. The essentials in order to survive, such as food, water, shelter, etc., are already there, so we don't have to worry about those. So I want you to read through all of these items or activities, and I want you to pick your top 5. You can either write them down or just in your head, pick them. I included number 27 as a personal item that you can add to your list if you want, if you see something that you really love that I haven't included. So I'll give you just a few moments to read through those and pick your top 5. If you were stranded on an island for 1 week, what do you want with you? But only 5 things. And remember, food, water, shelter, all of those necessities to survive, they're already there. So just the things you want to do in your leisure time, your free time, and you're going to have a lot of it. So now from your list, I want you to pick the number 1 thing that you would like to bring with you. The number 1 thing. And if you can you type it into the chat and also tell us why you brought that item, if you can do that. And if a few people would volunteer to share, maybe raise your hand or unmute as to what you picked and why. Any volunteers to share? Oh, people are saying, Kathy says books. Diane says books, music, iPhone, a pet. Jessica says wine isn't on the list. Gym gear, exercising in nature calms me, makes me feel at peace. Yes. And there's tons of research about have we talked about that in one of these sessions? I'm sure we have, where being out in nature just makes you feel better. So exercising in nature, excellent. Paintbrushes and canvases, because they are my soul. Cooking supplies. Jessica, Kathy is saying, Jessica, cooking supplies, and you can make your own wine. You could maybe on this island. And Susan is saying, books, pet, husband, is he a thing? Art supplies and yoga mat. Michelle says scrapbooking. Jessica, cooking supplies. Cooking is your escape. It makes you feel connected because it's about what I'm putting in me. Yeah, absolutely. And a deck of cards. So thanks for sharing, everyone. Oh, Susan also says paddleboard. I think that's 6, Susan. You can only take 5. So our objective in this was to clarify your values in relation to leisure and to strengthen your decision-making skills related to prioritizing leisure interests. And hopefully doing an activity like this, if you haven't done something in a while, will give you the motivation to try something or try something new. All right, so a big thank you to Jessica and Tracy for sharing their time and insight with us here this afternoon. And a big thank you to each and every one of you for being here today. Recordings of the webinars will be available on the Sask Pain website. The link to these will be shared with you by email. An email will be sent out to you tomorrow with any slides that our speaker will be sharing, handouts on the activity, and other helpful links. It will also include a link to an evaluation. Please make sure to complete the evaluation and provide us with your feedback. Our next webinar is scheduled for Tuesday, February the 15th at 6:30 p.m. And our theme for the webinar is biomedical dry needling. Please share this information about this webinar with your family and friends and social circles. And thanks for joining us. Bye. Have a good afternoon.